That you said earlier in the course of our discussion is a top priority. So just give us a little bit more explanation on that.
For many reasons. That's one, it's really unacceptable, given the technology we have, that a positive pregnant woman should transmit HIV to his or her baby. If you go to the UK, if you go to even less developed places than the UK, they will tell you that they don't know the last time that happened. But the embarrassment we have is that Nigeria has the largest burden of this. We are responsible for almost 29% of the global burden of this. So it's really an embarrassment. The second reason is that it is one of the ways in which the lowest hanging fruit for saving lives. Because if nothing is done to these children, nothing is done, in 2 years, most of them are dead. In 5 years, none of them is alive. And if you want something to be done, if they are positive, then you have to give them drugs. And that's, you can imagine taking drugs from almost when you are born to throughout your life for now, because we don't have a cure. So you see why it's critical for us, to ensure that, we address this. Many of the children who die, either as infants or childhood, have HIV. Between 10 and 15% of the women who die giving birth to life die because of HIV or related diseases. So this is really a low-hanging fruit if you want to save lives. And that's why it's critical for us. That's another very important reason. If you look at all the MDGs, HIV is related to all of them, from MDG 1 to MDG 8. But the door to ensuring that HIV gets into all this is through this process. What am I saying? If you take the pregnant woman, in order for us to identify that this woman is HIV positive, she's got to go to antenatal care and remain in antenatal care. Because every woman must be tested. For us, there are like 5-6 million pregnancies in this country every year. And obviously, as we've said, if you now can address HIV in that form, it impacts on every other thing. We know clearly that people who have HIV are much poorer. They have issues with hunger. We also know clearly that one of the reasons why we must address education, particularly girl-child education, is ensuring that we can empower the women. And if we empower the women, their risk of developing HIV is much less. In fact, 60% of the women, of all those who have HIV, the 3.4 million people are women. And the reason is because of the disadvantaged position of the woman in society from her political, her social, and economic status. So if you raise the girl child, and you raise education generally, you can address this.
There's no cure. But how would you, react to this claim, or recent claim that we heard that there's actually some, cure for the scourge of HIV and AIDS? What's your reaction to that? Perhaps you might have one or two things to say about this.
Well, when I say there's no cure, what I mean is that the drugs we give now, they're not a cure. Yes, there have been 2 isolated cases, well reported, and I think I need to make mention of this. One was a baby that was reported sometime early this year, at one of our big conferences. And this baby was a young baby, was born, identified to be positive, but, when they gave the drugs at a very early stage, it was able to suppress the whole, virus in the system. Those are 2 very isolated cases. And if you remember that there are over 33 million people carrying the HIV virus, this is not something that can be done on a routine. The only answer that we're all looking for is a vaccine, and that is very far away. A vaccine that can prevent HIV. It is only then we now know, that yes, we have overcome the epidemic. Right now, there may be these isolated cases. And by the way, there are many people in this world, I won't say many, who have HIV, but it doesn't do them anything.
Now, since the coming of the agency NACA, or since its establishment, 3.4 million Nigerians, you say, are living with the HIV and AIDS even as we speak. But would you say the number has, declined, or is it increasing? Is it still increasing at the moment?
Well, the number has hovered around 3.4 million. And it's not surprising. Has the population in Nigeria remained static? The answer is no. Because these are projections. What happens is that we look at the prevalence in various populations or among pregnant women. And then we now use a software to look at, the population. Nigeria now is about 170 million. So, if 3.4 million of this is HIV positive, it's a lot better than, 3.4 million when we were like, 140 or thereabout. The truth of the matter is that, yes, there has been a gradual decline in the number of new infections. But the problem Nigeria has is that we have huge populations. And the thing about our population is that it's like a pyramid, with a huge base down, What I mean by that is 70% of the population is below 30. 45% of the population is below 15. So every year you can see the number of young people moving from no sex to sex, perhaps with very little information about how to protect themselves from sexually transmitted infections or even HIV. So every year you're having this huge cohort, moving into sex without adequate information. That's one of the big issues that we have, trying to drive enough information to people. Most people are aware about HIV, but whether or not they can change behavior to ensure that, they don't contract it, it's a whole different ballgame.
So how do you feel the states and indeed the local governments, how can they come in to really drive the message home, in terms of the behavioral lifestyles of our youths in trying to address this trend of HIV and AIDS?
This is where, we're doing a lot of things now. First of all, being very strategic. We've looked at the map of Nigeria in terms of the prevalence. And about 12 states and the FCT are responsible for 70% of the burden. So we're asking ourselves, if we want to invest wisely, if we want to invest in such a way that we have good returns by lowering the incidence and the prevalence of HIV, we should actually be going after those 12 plus 1 states. So we're actually doing that right now. Our activities are going on around the whole country, but we are driving it more in these 12 plus 1 states. In doing so, we can now address not only HIV, but, other infectious diseases like TB, malaria, and then we're addressing maternal and child health. So this is one of the things that we're doing. But it's got to be, a project or program of the people, for the people, by the people. That's the way to do it. And if you do it that way, because it's owned, it's sustained. That's even the research that we're trying to do now. We're trying to use local social scientists, from the various universities. If you go to every state now, all states have universities. There are social scientists. We're not using enough of them. It's easy to say, I go to a state and I say, it's because of TBS. It may be more than that. So the question is, can we engage the social scientists working with us to identify what are the root causes of why, a state that is so rich, only 8% of the women, go to antenatal care and get tested. So these are all the things that we're doing, trying to make sure that what we do is evidence-based, and what we do is partnering with the communities and making sure that it's sustainable. But the primary health care is the focus. Because if we do HIV, we do blood pressure, we do diabetes, we're actually bringing health, and human capital development to the community.